So, good morning, good afternoon. Welcome to our long-awaited webinar on teledermatology from different perspectives, of course, patients, physicians, and policymakers. We will slowly start, and I see that there are still people joining. I'm really happy to see you all joining today. My name is Yalchin Mamadov, and I am Senior Advisor for Europe at GlobalSkin. I will be facilitating this webinar today. The webinar is co-hosted by the European Dermatology Forum and GlobalSkin, International Alliance of Dermatology Patient Organizations, champion of dermatology patients' voice globally. So get ready for 2 hours of interesting discussions because we are having a wonderful panel and a lovely audience representing large scope of stakeholders. Before diving into the topic, some housekeeping rules, and Nicole, please also feel free to add if I forget any housekeeping rules. First of all, the webinar is recorded and will be made available for the whole community later. Keep your microphones off when you are not speaking, and when you're speaking, of course, keep them on. And when you're asking questions, please introduce yourself. There is a QR box in the bottom right. If you have questions to address to the panel, or if you wish to express your position on discussed issues, you can write it there. There's also a chat function in the lower bar to interact with each other. So, but if you have questions for the panel, please remember to write it in the Q&R box, so that they are not lost. Finally, I trust that we are not going to interrupt each other and have a smooth discussion. As I said, we have a unique panel today with excellent experts, including Carla van Sluisdam, patient leader from Dutch Skin Association, Gunter Van Dyck, patient leader, developer of the E-Derma digital solution, Professor Matthias Augustin from University Medical Center, Hamburg, Professor Alexander Navarini, Secretary General, European Dermatology Forum. Last but definitely not least, Ioana Alice Postu, health policy expert at the European Parliament. Now I would like to give the floor to Tammy Shipwick, Global Skin Programs Director, for opening remarks. Tammy, if you are ready, please activate your microphone and the floor is yours.
Thank you, Yalchin. Hello, everybody. Welcome. Good morning, good afternoon, possibly. I don't know if it's good evening for anybody, but I welcome you here today and this webinar, Leveraging Teledermatology, Perspectives in Patients and from Patients and Practitioners. I'd like to acknowledge and thank our co-hosts from the European Dermatology Forum for partnering with us on this webinar. The topic of today's event was identified as a key priority by our European members. GlobalSkin's European community is comprised of 136 patient organizations in 29 countries, and they represent 22 different skin conditions. These members have seen teledermatology and the remote diagnosis and management of skin conditions rapidly transform access to care for patients across this region. Today's webinar brings together patients, practitioners, and experts who will discuss how digital dermatology can do just that: improve access, quality, and continuity of care while addressing emerging challenges. We look forward to hearing from our group of esteemed presenters who will bring these different perspectives to the table. Firstly, patient experiences, including their needs and challenges related to teledermatology. The practitioners will speak to how they are adapting to virtual dermatology care, and we will hear policy research insights on how teledermatology is being integrated into health systems. With the adoption of the skin disease resolution at the World Health Assembly this year, there is an increased awareness for the need to investigate skin health into health systems at the national level, and how dermatological care needs to be made more available to more people around the world. And teledermatology seems to be such an avenue. So I'm keen to get this conversation started. And so with that, I'll turn it back over to Yelchin Mamedov, our GlobalSkin Senior Advisor Europe and facilitator for today's discussion. Thank you, and thank you again for joining us.
Thank you very much, Tammy. Without waiting any longer, I will give the floor to Gunter Van Dyck. He's from Belgium, from Belgian Patient Association of Allergy and Atopic Dermatitis, who also has an extensive knowledge on digital health solutions. Gunter, the floor is yours.
Okay, thank you, Yelchin. Good morning, afternoon, or perhaps evening. My name is Gunter Van Dyck. I am the chairperson of Allergienet in Belgium. I also led our own teledermatology e-health initiative. It was called E-Derma, and it was a specific solution for chronic dermatology conditions. Besides that, I am also somebody living with a chronic skin condition. I am an atopic dermatitis patient. Next slide, please. So before we talk about digital tools and innovation, I think we should talk about chronic skin conditions and take a look at it, because being a patient means having symptoms, and having symptoms affects a whole range in our life. It affects our confidence, our work, our relationships, our mental well-being. It, of course, can bring stress, shame, loneliness. And also, in my experience, there are more and more healthcare barriers in our healthcare system. Often long waiting times, there is a travel burden, sometimes there is difficulty accessing care when it matters the most. And yes, unfortunately, there is also a financial strain that chronic illnesses bring. So, in my opinion, this is our starting point. This is where the story of teledermatology and e-health should begin, not with technology or commercial gain, but with our daily lives and challenges. Next slide, please. So, what we mean by teledermatology, we all know the standard definition, but in my personal opinion, that definition is a bit too narrow. I think teledermatology should be more than remote diagnosis. It should offer reassurance, continuity, education, and also guidance. It is the support between the in-person appointments, and it should empower us patients to be able to be more informed and take better decisions and take better care of ourselves. And next slide, please. So why we patients or parents need teledermatology? It's simply because our diseases do not wait until the next appointment. Teledermatology can give us faster access to medical care when we really need it. It creates continuity between appointments. It can reduce travel time, waiting times, and of course, the ongoing stress. it can provide reassurance on moments that there is no in-person contact. The feeling that somebody is available there to help can give a lot of reassurance. I think it could be a fantastic tool to deepen the communication between patients and their doctors, and it can provide much insight. So I think digital care can be a valuable resource of data, and it could help science and it could help dermatologists see what they cannot see during a single or often limited in real life appointment. And of course, perhaps, artificial intelligence could play its role and could help analyze data. So I think evidence indicates that digital support can actually improve our outcomes, I think, in our daily lives. Next slide, please. So we're skipping a few slides, I think, but it's no problem. I will go on with this. Okay, thank you. So there are challenges for patients in teledermatology. There is, of course, the risk of a digital divide. Not everyone has the same skills or access. There are quality concerns, I think. Also a bit the risk of loss of personal connection with your caregiver or with your physician. Of course, there are privacy concerns. And sometimes digital tools can be too complex, or with prolonged use, it can also demotivate us to use those digital tools. So I think, in my opinion, I think digital care should aim at reduce inequalities instead of actually creating new ones. Next slide, please. I wanted to shine a bit of spotlight on a commercial teledermatology app, which is at this moment active in Belgium. We do not have many initiatives running at the moment. Now, this specific app I want to talk about is a very simple and straightforward system where patients are offered a kind of asynchronous chat-style messaging system with a dermatologist. It's you could compare it to WhatsApp actually. It's kind of the same interface. As a patient, you can upload photos, answer questionnaires, and receive a diagnosis and prescription. You receive your prescription also digitally, which is linked to your identity card. Now, the pricing of this service is dependent on the response time. And also one consultation equals one issue, meaning multiple issues require multiple payments. Next slide, please. This model raises some concerns for us patients, I think, because we did an extensive test of this tool and we found that from a patient's perspective, we have some concerns. First off, the model creates a two-speed healthcare system based on the ability to pay. Faster care becomes something you buy, not something based on the actual medical need. When needed, there is a referral system in place to a specialist or a hospital, but it potentially discriminates against other patients regarding the waiting times for accessing the specialist at the hospital. Secondly, chronic patients often have multiple issues, which means that we have to pay multiple consults, which creates a financial burden. Third, as far as we know, there is no integrated care pathway. There is no automatic continuity with your general practitioner or dermatologist. Fourth, patients upload intimate data without full transparency about storage, access, or revocation rights. The commercial firm which offers this service could actually sell this data or do research on it, but we don't have any control over it. Fifth, there is no structured long-term follow-up or education. This is an episodical digital care model, so there is no room for chronic care management. And finally, in conclusion, commercial incentives may influence priority, but the platform, I think, should not determine the referral speed or access to healthcare. So in my opinion, digital care should reduce inequality and not commercialize priority access. Next slide, please. When we were working on our own e-health solution, we were confronted with a whole lot of challenges and barriers. I'm going to call them system barriers. So to start with, we were confronted with a very complex regulation across multiple layers of governance. There was the challenge of communicating with a fractured infrastructure with multiple systems, multiple vaults and hubs. There were heavy local requirements for recognition and reimbursements for us. There was no quality framework for teledermatology or e-health at that time, which we could use. And of course, there was a very high development costs, and which created a limited market access for us as a development team. It was very challenging and very difficult for us to work with hospitals and with individual dermatologists because of the uncertainty about regulations, but also the uncertainty about revenue models. And in some cases, there was even resistance to using new technologies. Another point which was confronting to see was that big corporations who are at the moment controlling the digital market and data flow in hospitals, and who are almost forming a kind of monopoly system, it was very hard to break in or work together with them. So all those system barriers, they block, in my opinion, innovation. And I think if innovation is blocked, we lose perhaps solutions, and then of course innovation stalls. So that's not such a nice evolution at the moment, I think. Next slide, please. Now there's something else. The price we as patients pay to use e-health and teledermatology. In fact, we share our digital bodies, I think, because of course, the more data you make available, the more insight is gained. So to have the best possible results, we must share a lot of information, but this data for us is not just a picture. It's actually kind of an open window to who we are. Our data could contain biological, but also emotional or identity information. And I think we must not only fear the possible misuse of our data, but also the loss of control of our data. So who sees my data, for what purpose, for how long can a person see my data, and when and how can I withdraw access in an easy manner? Or even, do I know who has access to my data? And for that, I think we need more than just individual apps or individual development teams or individual hospitality systems. I think we need a more unified, secure digital health vault, one or more. And such a system, by the way, could be enormously beneficial for for the whole of our e-health ecosystem, I think, including the developers. Next slide, please. Which brings us, of course, to our digital rights. I think if we share our digital body, then we need digital rights. We need clear ownership of data, transparency of access. I think digital care should be safe, ethical, and of course, trustworthy. Next slide, please. So in my opinion, how to build a patient-centered teledermatology app, I think we should go for hybrid care. I think we could use digital where possible, but physical where needed, or when there's an ask from us as patients. I think we need to invest in digital inclusion, especially for vulnerable groups. And I think we need digital tools that support education and mental well-being. and this at a zero cost for patients, because I think digital care could save society time and money. So it should be at zero cost for patients. It should never create costs for us as a patient, additional costs, I mean. And finally, as mentioned, I think there is a need for a unified digital health vault with full patient control, which actually should become part of our digital identity. And I think accessibility is not only clinical, it should also be ethical. Next slide, please. So my closing message is that digital care must always remain human care, because in the end, technology does not replace connection, it facilitates it. I think patients should have a strong voice, so we safeguard our rights and stay in control of our digital body. And if it's done right, I think teledermatology can truly improve our lives in the future. So thank you very much for your attention.
Thank you very much, Gunter, for sharing your expertise and your concerns. We will come back to those issues during the discussion. Now, Carla van Sluisdam, she's an active member of Dutch Skin Association, and I think her commitment and expertise allows her to convey messages about the patient's preference around the teledermatology and patient's experience. Carla, the floor is yours.
Thank you, Yalcin. Hello, everyone. My name is Carla. I work for the Dutch Skin Alliance, which is the umbrella organization for patients' organizations in the Netherlands. Next slide, please, Nicole. Our mission is to improve the quality of life of people living with chronic skin and hair conditions. We bring patient perspective into healthcare discussions and promote multidisciplinary collaboration and advocate for the message that a person is not their skin condition. Next slide, please. Some of you may know us from our international project Skin at School, developed and promoted together with GlobalSkin. And next slide, please. I'm happy to see that Gunter and I don't tell exactly the same story, but there will be some overlaps, of course. Why teledermatology? That's quite a breaker, that word. Matters in the Netherlands. Given rising healthcare costs and expected workforce shortages, digital health solutions, including teledermatology, are becoming increasingly important in the Netherlands. This national focus on digitalization may give dermatology a real boost. Until now, digital tools in dermatology seem to have developed more slowly compared to other areas like, for example, diabetes care and cardiology. Even though the Netherlands is a small country, distance still plays a big role in accessing expert care. If you live in the south and your expert center is in Amsterdam or Groningen, you may have to travel for hours for each appointment. And for people with chronic skin conditions, pain or fatigue, this travel burden is real. Since COVID-19, online consultations have increased, but traditional face-to-face visits remain the main form of care. Teledermatology can reduce strain, but we are not using its full potential yet. The digital landscape is fragmented and confusing. Every hospital uses its own digital platform, and every GP uses a different system. Sometimes even your GP's platform doesn't communicate with your pharmacy's platform. For patients, especially those managing long-term conditions, this means juggling multiple logins, different interfaces, different rules, and sometimes no clear guidance on how to use these tools. We also have apps for flare-up tracking and for well-being, like Positive Health and GlobalSkin Sprit. People use them when encouraged by clinicians, but not usually consistently. A key factor influencing all of this is digital skills, both of patients and professionals. Next slide, please. Of course, there are benefits and challenges for patients. Potential benefits are easier access to specialist care, fewer unnecessary trips to hospitals, better self-monitoring of systems, more frequent touch points without increasing the workload for clinicians. But there are also important challenges, especially for patients with low health literacy or limited digital skills. They risk losing access instead of gaining it. Teledermatology can unintentionally widen the gap between those who can use digital tools and those who cannot. Ideally, a personal health environment would collect all data from all providers in one place. In practice, people need to navigate many different systems, which causes frustration and reduces engagement. The last few years in the Netherlands, the government has put priority on these personal health environments, but it's something that's not used by many patients. From Huid Nederland, we have had a project using the personal health environments and making people familiar with it. But I think the results of this project only showed us that it's still a long time before we can fully use those systems. Next slide, please. So what I think we need to improve is that we listen to patients when designing platforms and apps. Don't build digital tools about patients without involving them early. And test those platforms and tools with people who have low digital skills and low health literacy. Think inclusively and practically. Add translation tools directly in portals and apps, because Dutch and English aren't the only languages spoken in our country. Use clear language and use simple workflows. Make it possible to upload photos easily. Ensure accessibility for people with visual or motor impairments. And let's not forget that human connection still matters. In online consultations, you also take a moment to arrive in the conversation. Just like in a physical treatment room, connection and trust take a few seconds to build. I think teledermatology offers great opportunities for people with skin conditions, but if we want it to work for everyone, we must design it together with the patients and reduce the digital barriers. Keep human connection at the heart of the care. Thank you.
Thank you very much, Carla, for this very interesting presentation and messages. Now we have heard a patient's perspective. I think it's time now to hear what physicians and practitioners think about teledermatology. For this, I will give the floor to Professor Matthias Augustin. If you are ready, you can also share your slides. Lovely.
Yes, I will do so. Thank you very much. Yeah, can you see the presentation now? Yeah. Thank you for inviting us, Professor Nabarini and myself, to give you an overview on at least some perspectives, some insights from those who use teledermatology as dermatologists. And I can already start and announce that a lot of what we just heard in these two excellent previous lectures also applies for us. So there's not that much discordance between the views. I have to give a declaration of interest because I'm the first author of the German guideline on teledermatology, and I'm in charge of the German program for certified teledermatology. And in my clinic, of course, I'm in charge of digital dermatology, and I give consultations to companies working in the field. Now, when I wake up in the morning, you see here my alarm clock in my mobile phone. The first thing which welcomes me is a post from the night or a message which is a request to help. As a dermatologist, of course, we are ready to also see at such photos, and probably we have an idea on this. But the question is this good or bad? It brings us teledermatology in general the word closer, and we may even define when or when not to react on this. But there's also an issue of data safety and surely also on patient safety when we work in this informal way. But just to sort this and to give you a systematic overview, let me just give you some definitions. Where are we allocated with teledermatology? Gunter already made the point that there's need for such a definition. And if we talk about digital medicine, this means all medical applications based on digital technology. And telemedicine is this part of digital medicine which uses remote transmission of data. So if you want, this is digital medicine in red and telemedicine in green. And then we have a more encompassing term, e-health or digital health, which means all digital implications in the health sector, even if non-medical. So it's even more encompassing and also includes consumer-related applications. So telemedicine can be teledermatology, cardiology, radiology, and many more. And digital medicine also encompasses beyond telemedicine, AI, big data, robotics, and many more of these innovations. And of course, they may be combined in a single application. And further areas of health, e-health, may be health apps or smart lifestyle devices. Again, they may be useful even for the medical field. And one thought is to integrate them into common solutions in the future. Now, a second and last point on the systematics, when we create a line between the patient and a telemedical center, then we have two basically different options. One is to have a store and forward technology where data from the patients are stored first and then taken up by the telemedical center. We call this asynchronous or store and forward technology. The other is to interact directly in a real-time mode or synchronous operation. This is one of the two which is made in most applications worldwide. In my department, we, for example, do teledermatology for sea ships all over the world, and this is asynchronous. We care for wounds in nursing home, which is asynchronous, but also we do nursing home telecare, which is a direct video conference. And in our online teledermatology clinic, we do both as needed. One of the large fields that we have is serving for most of the prisons in Germany. Obviously, there is not a big distance, but big hurdle to reach the patients there and vice versa. And here you see two of my attending senior dermatologists who are interacting with the GP in the prison and with the patient, him or herself. And in that, we use a hybrid teledermatological approach, asynchronous because we get the photos in advance with higher quality, and then a synchronous video consultation, which permits to interact and have a better understanding of the patient and a better B2B connection to the GP. Another example, when we care for sea ships, maybe cruise ships like here, then we get requests from all over the world, like in this case from the Atlantic, far from Madeira. And this was a request some years back where they sent us a consultation request for a young 6-year-old girl. You see the girl here, and she obviously had a rash and exanthema. And the question was, is this measles? Because measles would mean that she would be locked in to the hospital of the ship and could not talk to others. And also it needed to be found out who was in touch with her in the days before. But luckily, this was erythema infectiosum, so harmless. And instead of being imprisoned almost in the hospital, she could play again pirates with the other children on the ship. So obviously, there has been an immediate value to the patient, to this girl. And the question is, what is needed for us as practitioners for value-based teledermatology? And I will lead you through some of the thoughts about this. And one need is surely that we need to have an agreement with the patient on how and if to use teledermatology. And we have a three-lingual guideline, three-country guideline with Austria, Switzerland, and Germany on teledermatology. And Professor Namarini, who will talk after me, is one of the co-authors. And this guideline, we ask patients, what are your most important points? And we heard some of them already in the previous talks. And these 10 guiding principles from the patient perspectives are always at the beginning of considering teledermatology. Just some examples. Patients say they must benefit, obviously not the payers. There needs to be the same diligence as in-person care. The data protection is an issue, patient consent, and also empowerment needed to have e-health literacy. And finally, we need to respect the patient need for personal care. If this is prioritized, then just additional teledermatology or not at all. Second, we need the issue of safety. We need to have an understanding of what means trust to the patient. When does she feel safe? And we need to protect patients from approaches which may even harm them. In order to have a system on this, we have identified risk assessment scenarios for teledermatology, which is also in the guideline. And one scenario is that we know the patient from a presence consultation and then do telemedical follow-up, which means that there's enough information and also concordance with the patient. The same is when it's alternating between presence and telemedical consultation. They are quite safe. There's a higher risk when we start telemedically, when we don't know the patient in person, but then have the chance to invite the patient in case of any uncertainty. And the highest risk is when we never see the patient, but if it's all online and there's no chance to discuss, no chance to really verify what we find. And this, of course, is better, and there's less risk when a nurse or doctor is involved on the patient side. The highest risk being self-assessment apps from the patient, which is not controlled by healthcare professionals. Now, the other point is the patient need for healthcare professional presence. And we should not underestimate the value of touch and the value of talk with the patient. So this is something we need to verify as indicated already. And then there's the need of evidence and guidelines. This was mentioned already, but we take this very serious, and we want to have at least the same level of quality in the healthcare telemedically than when in presence. And so we worked up the evidence and the guidelines. And just to give you one depiction, this is a systematic review on the worldwide literature on teledermatology, which we published 2 years ago. You see in the map, there's publications from many countries in the world, but not from all. And if we go into the different fields of digital dermatology, teledermatology is the largest with 43% of about 500 studies. Then there's AI, there's e-education for healthcare professionals, trackings, e-education for patients, and the population as a target of e-health as well. If we go into some details, I don't want to go through this with you for the sake of time, and it's also very busy, but I want to let you share some points. One is in terms of the indications in the evidence. Skin cancer is on top with most studies, but also general dermatology, wounds, psoriasis, atopic dermatitis. In terms of the interventions, diagnostics and triage are most frequently observed, monitoring as well, but also prevention of treatment. And in the outcomes level, it's mostly about diagnostic performance, but also acceptance, effectiveness, efficiency, and also usability in many of the publications. You see, this covers already a broad spectrum, and in a single patient case, we need to verify where are we in terms of the evidence. Beyond the evidence, we also want to make sure that there is a sufficient technical quality and quality assurance, because the best evidence doesn't serve us if the derm is not, or also the patient, not capable of using the technology accurately. In order to do so, in terms of quality assurance, we check how good are we? And this is different scenarios of teledermatology at my university institute in Hamburg. And you can see in dark green those consultations that we were able to solve directly without any further requests. You can see it's quite high. If we were able to solve the problem with re-questions, this was light green, and in red, those red flags where we were not able to solve the problem. And so this remains about 20 to 15% also in the literature. And we, of course, need to be very sure about any single patient who we treat teledermatologically. And this leads to the point that the technology is not a single standalone technology, but needs to be placed into an environment, a working environment. We call this the digital working environment. And there's two levels. One level is the level of digital onboarding, which happens even without us as derms. And then there's the level of the in-presence talk or the direct talk to the patient, which should be the even larger basis of the decision-making. And of course, we make use of the digital level and dashboards, as you can see here with many data, before we decide with the patient in a shared decision-making process. All this is what we call IT-assisted care, or sometimes AI-assisted care, if AI is involved, and Professor Navarini will come back to this in a moment. So in order to be efficient and also have a full understanding of the patient, we start the digital process, not in our clinic, but with the patient at home, even those patients who come for a visit. And this is depicted here. A new patient gets an online appointment, even without our interference. And when getting the appointment, he populates and fills an electronic health record that he gets from us and that he owns in the future. And we can have a review and triage of the patient. And at the first appointment in presence, we have all data available. We can make use of the data and the registry, and for AI purposes, all in a shared decision with the patient. And this is a typical view on the dashboard for a real-world patient from our routine. Some general information. This is a grid that we get from the patient even before the patient is there, so that we know about the distribution of the lesions. We have many scores, patient-reported outcomes. You may know DLQI, but many more that we use for the decision-making. We have the comorbidity screening and also the drugs and the comorbidity overall. All this is a much better and much more profound depiction of the patient than just looking at the skin in a very quick picture. This all needs physicians' training, and we need a person-centered digital literacy of the doctors. And a nice publication recently summarized the upcoming additional tasks of doctors, like being confident with AI, with precision medicine, wearables, with digital avatars. All this creates a completely new field, which is not just nice to have for us dermatologists, but which we need in the future in our education. There's also need of incentives, and incentives means that all parties participating need benefits. The doctor, also in terms of the reimbursement, the patients overall, they need to have their benefits, but also payers when this should work. Finally, we need an individual benefit risk assessment on a single patient level, whether we can justify to see him just online or we need to see him in presence. And here you see some patients with psoriasis. There it may be easier to have an online management of the patient than with, let's say, tumors, where we also want to see what happens beyond this photo that we get We want to see the whole patient. We want to talk and have our own examination, again, also with chronic wounds. Benefit risk assessment on an individual level. So let me summarize my advice that I give to the derms. We should use teledermatology if beneficial. We need to respect and understand the patient view. We need to know the evidence on when to do what. We should use the guidelines, and there are several guidelines. We need to always to optimize technology, be aware of the risks, get good training. It's not just that we get the training from medical school, but it's additional training. And we always need to see the win-win-win between the patient, the doctor, and the payers. And we shouldn't forget the patient need for us in present. I think this is very much on top. And with us, I think we should do teledermatology as needed for better care. And with this, I thank you very much for your attention. And I hand over to Professor Navarini, who will focus on AI.
Perfect. Thank you, Matthias, for this very nice presentation. I have just a few additional points that we dermatologists think are quite important. And this is about AI used in teledermatology. And I thought your point with the AI being the most at risk for patient actually very crucial. So here I actually directly brought you from the regulatory kitchen the classifications for medical devices. This applies for the whole EU, but there are similar classes in the US. And we see that these are all that are for all devices that are used in humans. And so the MDR class 1 is lowest risk. So basically any photography device that doesn't think, it has an MDR class 1. MDR class 2A is already some decision support. So the dermatologist gets some hint what the device thinks, what the case might be, but the human must be still involved. MDR class 2B is almost similar. It's a little bit already with a higher risk involved. And MDR class 3 is the highest risk. So basically here, the device makes the diagnosis and the triage autonomously. Now, we as dermatologists have observed that companies who bring devices on the market do not always stay within these classes. But also patients who use devices do not operate according to the classes. And perhaps the most clear example for you would be the ChatGPT. So ChatGPT and Google Lens are not medical devices, and they're not intended to provide decision support for any disease, but they are used all the time to make a diagnosis. And they're not so bad, as you can see here, with different conditions, so acne, vitiligo, and here in green, psoriasis. ChatGPT can make the correct diagnosis in 95% of known plaque type psoriasis images that were uploaded. So it is clear that many people use it, but still there is no legal implication, there is no responsibility. And it might even be that within the EU at least, such uses will be barred if the OpenAI will not try to register ChatGPT as a medical device. So in effect, it should not be used. Then we have some devices, some applications that take money to make a diagnosis. So here is SkinEye. The patient journey here is the patient uploads an image. The AI scans for more than 50 skin conditions. And then it will give you can see that here on the right in German. So it will give you a presumptive diagnosis, a risk evaluation, and that is directly the payoff for the patient. But indeed, the class that it has is just class 1. So basically, it is just a passive photography device in respect to the legality. And so therefore, I would say that this is not illegal in its use for patients, and it could well be that it is taken from the market in the future. Then we have Skin Vision. This is from the Netherlands. And so basically, this is an app where without dermoscopy, without magnification, just with a smartphone, patients can make photos of their moles. And then there is a risk evaluation, whether that mole is suspicious for being malignant or not. Okay, so far seems very unproblematic. However, when we evaluated how well that app works, in contrast with better methods, for example, the gold standard of a dermatologist evaluation, the app actually led to 27 times, more false positive melanoma risk diagnoses. So that means that there are many false excisions, false operations due to this app. If the diagnosis made by the app is followed directly, and that is a huge problem. In respect to the classification, at least the class 2A is correct if a dermatologist is involved with the diagnosis of the app. But if the diagnosis of the app were to be used directly to decide about the operation, that wouldn't be correct. And we are afraid that this is actually the case. And so now in the UK, there is actually one single app that has MDR class 3. So this is an autonomous app. It can decide on its own whether a skin lesion is benign or whether it needs to be excised. So I will directly show you the pathway, how it works. And just suffice to say that there are now almost 200,000 patients already assessed across the UK, and the NHS has the clear plan to use this app to overcome the shortage of dermatologists. This is a slide that I'm typically showing to dermatologists, but it is very easily understandable. It's actually quite a small study that led to the registration of the app. So just 622 patients with almost 800 lesions, and only 67 cancers were involved in that study. They compared with actual teledermatologists, standard of care, where the sensitivity was around 97%, and the specificity, so the ability to rule out disease, was about 72%. And the Derm AI had approximately similar levels. So that led to a provisional registration, and then they had had it on the market for a while, for now 3 years. They have now evaluated 45,000 lesions, and you can see here on the right the target and the actual values that they achieved, without explaining now in detail for what all these different numbers mean. You can see that the target was actually always reached, and so therefore that device is now firmly on the market. The way it works is actually quite simple. So let's have this 42-year-old patient with a new darkening mole. He goes to the GP. The GP will flag urgent suspected cancer. He books an appointment in the rapid access clinic. Then on the site of the university hospital, there will be a professional medical photographer making an overview photo, a close-up and dermoscopy photo. Then the AI is involved. It will analyze. If it says it's a clearly benign case, the patient will be directly discharged. If it is saying that it is malignant, then the teledermatology team, the human team, will still validate, especially if patients are pigment rich, because for white patients, the app was trained in a stronger way. For darker skinned patients, not so much. So in the end, the outcome, if it's benign, the patient is discharged. If it's suspicious or unclear, then there will be a rapid clinic slot for excision or biopsy, depending on the provisional diagnosis. And with that, the NHS reaches the goal of making a diagnosis available to patients within 28 days. That is now the most modern development in AI-driven teledermatology. And as well, how we are going to react as dermatologists, whether this is something that in the end is changing patient pathways in a significant way, is still in the future. But in the end, I think for patients, it's probably very positive that in overwhelmed healthcare systems, such as in the UK, they get a diagnosis in a much quicker way. Thank you.
Thank you very much, Professor Augustin and Professor Navarini, for useful and extremely interesting insights. And I think all these perspectives now require a view from a policy perspective, seeing how all this fits into large policy initiatives, large policy. And happily, we have Joanna Alice Poster from European Parliament, who is here. And Joanna, if you are ready to share your slides, the floor is yours now.
Joanna, you are muted.
I take the opportunity to remind the participant that you can write your questions on the Q&R box on the bottom line. And of course, there will be a possibility for all of you to ask questions.
Good afternoon. Thank you very much, Yalcin. I will try now to share. I hope you can see my slides.
Not yet, but it's coming.
Yeah.
I think a couple of seconds. It will be here.
Maybe now.
Still not, because we are seeing ourselves.
Otherwise, if you'd be so kind to share them for me,
no
please.
problem, Joanna. I will share for you.
Thank you very much, Nicole.
Thank you, Nicole. Thank you, Yalcin.
No problem.
Good afternoon again. Thank you so much for the invitation to the organizers. I'm very pleased to be here. I'm Ioana Postu. I'm a lawyer by training. I have 15 years of experience working for the European Union institutions. I have been working for the European Parliament, an EU co-legislator, for the past 8 years. I was co-responsible for several files in the public health policy area, including those linked to the European Health Union that we have been dealing with, particularly after the pandemic. And it was in this context that I also had the chance to engage on the telemedicine and digital health issues. So today I will walk you, if you'd be, yes, maybe next slide. I will walk you through a number of aspects that have to do with how telemedicine, how digital health is addressed, regulated at the European Union level. I start with two questions just to illustrate the implications of digital health and cross-border health in the European Union. So say a cancer patient diagnosed and getting his treatment in Germany needs to stay abroad longer than expected, is running out of his medicine and that he was prescribed in Germany. What do we do in the European Union, and why? How can we address such a situation of cross-border healthcare? Similarly, what if a person living in Portugal and traveling just for pleasure to Paris goes to see the local doctor and all of a sudden is required to undergo examinations, tests that he already was subjected to in his member state, in his country of origin? Now, the answer to these two questions, and more than that, I will try to share with you. Next slide, in the next few minutes. So here, just an overview of the different points that I will touch upon, particularly the European Union initiatives in e-health, the main European Union programs that support digitalization in the area of healthcare for the programming period 2014 until 2020, and then the current exercise running until 2027. We will look closer into the relevance of healthcare digitalization after the COVID-19 pandemic. So there, despite a limited legal competence of the European Union, in fact, several pieces of legislation were adopted, are being transposed, implemented by the member states. And thanks to that, patients and practitioners' lives are indeed more smooth. There's more predictability there, and also ultimately a safer cross-border access to healthcare. I picked just a couple of pieces of legislation that we will look into, the most recent one being the European Health Data Space that will run until, in terms of transposition and implementation by the member states, it's until 2031 that the different changes will need to be made in their systems, each member state's systems. And there, towards the end, we will look into the European Parliament's specific calls on telemedicine, on telehealth, how the European Parliament has been supporting these areas. And a number of aspects were already addressed by the previous speakers. It was very interesting for me to hear your views, your experiences. And indeed, as Yalcin said, now we are going to put the finger on precisely on the regulatory aspects of it. Next slide. Here you have an overview of the different initiatives that the European Union had in the past decades, and already the notion of healthcare online was first raised in the late 90s. Later, it became a binding law in the form of a directive on the application of patients' rights in cross-border healthcare, and already there we have telemedicine mentioned, specified, so patients from different member states can well benefit based on this piece of legislation from telemedicine. Moving on to the digital single market strategy, already also there, e-health, telemedicine were mentioned as tools to boost competitiveness in the internal market. And this strategy led later to the revolutionary, I would call, European Health Data Space Regulation that was proposed in 2022. And it was adopted a few years after, and it has been already published this year in March 2025 in the official journal of the European Union. We will see how the different the timelines and specific provisions and their implementation, actually with direct implications for medical doctors and patients in the coming years. And this I would mention just that the EHDS regulation, it was the its achievement was the result of huge efforts from both co-legislators side, the Council and European Parliament, just before the end of the previous legislative term. It was indeed its adoption was a success thanks to the push from the rapporteurs team in the European Parliament, and also to the Belgian presidency at the time in the Council that managed to get this proposal through after years of work and discussions with member states. Of course, this huge budgetary implications for every member state, but we will also look together into how the European Union is financing different kinds of projects that are linked to telemedicine. And in the next slide, you can see an overview of the main European Union programs that support healthcare digitalization. And these are, to name just a few, the cohesion policy, the European Union EU for Health program. It was in fact the largest ever health program of the European Union, with a large budget allocated just after the pandemic, when we realized indeed that despite a limited competence, we can make a change in terms of prevention projects in the member states, in terms of enhancing digitalization. So I would say the COVID triggered much higher interest for this policy and certainly prioritizing it. Then we have the Horizon Europe project that finances digitalization, digital transition, and I would move already, since we don't have that much time, to the next slide. So the relevance of healthcare digitalization increased greatly after the COVID pandemic. I would say that the social distancing measures already encouraged medical doctors to use the e-health, the electronic means to deliver healthcare during the pandemic. And at European Union level, we saw indeed room for increasing the action in many aspects that have to do with healthcare digitalization. It was the European Commission President that just during the pandemic announced that so much had been achieved without having full competencies, legal competencies at the European Union level in the area of public health. And it was the time when the concept of European Health Union was announced. And and it anticipated a number of legislative proposals that were going to be announced by the Commission just shortly after, which included also the reinforcement of two European Union agencies, European Medicines Agency and European Centre for Disease Control. You may be familiar with both of them. Indeed, also the question of health competencies was raised, and we are yet to see, we will see in the coming years whether there is going to be a revision of the European Union treaties that enhances the competence at union level in terms of regulation in these aspects. Now, next slide, moving to the European Health Union package. Here I mentioned just two provisions from the EU for Health regulation, which is in fact the health, as I mentioned, the health envelope of the previous MFF, multi-annual financial framework, the health envelope which actually specifies how the budget and on which priorities for which objectives the budget should be spent. And telemedicine, telehealth, e-health are explicitly mentioned, and the EU for Health is currently being executed, and different projects that have to do with telemedicine and telehealth directly benefit of such financing. Next to this box, you will see the EHDS, European Health Data Space, which I already mentioned. But looking concretely into its actions, what does it have to do with? It has to do with access, control, and sharing by the individuals, by the patients, of their electronic health data across the EU, and that we call primary use of data. In addition, the secondary use of data has to do with the use of such data for research, innovation, regulatory activities, and of course, ultimately, both the primary and the secondary use, they serve a single market for electronic health records. Now, I would give you an overview in the next slide of the other, just for your information, the different other pieces of legislation within the European Health Union, including the serious cross-border health threats and the pharmaceutical legislation reform currently being negotiated by the co-legislators, the Critical Medicines Act, which has to do with addressing medicine shortage in the EU. And we know that after the pandemic, we've seen that our dependence on active substances from outside the EU has put the EU in a vulnerable situation affecting patients. I would go to the next slide. And now, in fact, answer to the two questions we raised in the beginning of the presentation based on the legislation I just mentioned. And so a cancer patient that needed to stay away from their country of origin will, thanks to the European Health Data Space legislation, will be able to have his prescription delivered to a pharmacy in the country where they find themselves and get, of course, the medication they need. In the future, an automatic notification of this e-prescription will be submitted to the country of origin of this patient. Similarly, a patient that underwent different exams in his country of origin and finds himself abroad in the European Union should not need to repeat unnecessary medical exams. These can be put at the disposal, the results of such exams can be put at the disposal of the doctor that they see in the country they are traveling towards. And the key, this next slide, the key milestones towards a full implementation. And you have here an overview. Just the next slide, please. With an overview of the different milestones towards the implementation of the EHDS legislation. Already by 2029, member states should apply for primary use, meaning for patient use, should ensure a first exchange of the different of the first group of priority categories of health data, patient summaries, e-prescriptions in all European Union member states. Then moving towards the next benchmarks are 2031 and yes, and also 2035, that's when third countries or international organizations would be able to enjoy the and to apply to join the EHDS. I would like to mention in these slides also the European Parliament's specific work addressing telemedicine and telehealth. There was a resolution on non-communicable diseases linked to the European Commission initiative on non-communicable diseases, and their e-health technologies, telemedicine, telecare services are explicitly mentioned for ensuring continuity provision of inpatient, outpatient care. Also, there is reference to the Digital Europe program. You've seen it in a few slides before, amongst the different instruments via which the Commission finances digitalization of healthcare. Similarly, the Parliament resolution on mental health recognized that both the digital health, telehealth services have the benefit of catering and have the potential to cater for a broader population, including those in remote areas. The next slide, please. And the most recent file that the Parliament is working on has to do with the health workforce crisis that we are observing in the European Union. So this is called an own initiative report, whereby the Parliament is going to call on member states and on the Commission to address the current crisis workforce. And I think it was already mentioned by the colleagues before who spoke that telemedicine does indeed have this immense potential of reaching remote, underserved areas, especially for certain medical specialties, certain medical disciplines. In the draft report, there is a specific which you can find online using the code within brackets. There is a specific mention of telemedicine as a tool to address the health workforce crisis. I think I will stop here. Thank you very much for your patience, and I'm happy to take your questions in the coming minutes. Thank you.
Thank you very much, Jonalis. I wish we had more time to go through this broad issue. I know that 10 minutes is not, it is too small for such a big topic, but happily we have now time for discussions. And I will open the floor to the audience, of course. We also have some questions on the in the chat. I will perhaps start with reading Julia Garcia's question, and whoever feels comfortable with this question among panel members can answer. So Julio says, or Julio, I'm sorry for the pronunciation, Many health systems, such as the one in Argentina, still rely on handwritten prescriptions for medication, including dermatological treatments. How is the process of generating legally valid prescriptions handled through teledermatology? So, who wants to start? Yes, Matthias.
Yeah, thank you for this question. I think it's essential to also digitalize prescriptions when moving towards digital health. And just the German experience, for a decade, we missed the chance to introduce electronic prescriptions, but we did so last year or 2 years ago. And within just a short transition time now, most of the prescriptions are done electronically. So in my department, 95% of prescriptions are electronic. Those patients who are not able to handle them electronically, they still get a paper-based prescription. I think this is important, that we also think about the exceptions. And it's running very smoothly. And of course, there's much better also control and much better chance of analyzing these prescription data. So I think it's worth to change. And I think part of the question was also, is there any risk, any hurdle? And of course, the process of identification of the prescriber is important. And for this, every German physician got a special ID and a special card, like a check card, to identify when doing the electronic prescription. So it's rather safe also.
Right. Thank you so much. We also have a question by Roger Mabiala, who wonders, well, first he has a concern about database software for dermatology, and he wonders if there are any free and available online, easy to use. Well, I guess no one has the answer to this question. Yes, Matthias?
Yes, so maybe I can again comment on our perspective. There's a large number of software solutions to be used in dermatology in Germany, and I would say in Europe, in the European Union, and they all need to be approved. So there's no freeware solution which is just there to be used, but they have to have certain levels of certification, and without these certificates, they are not approved and cannot be used. I think this level of control and of quality assurance is needed for the sake of the safety of the patients.
Right. Thank you so much. I have questions. I mean, to all the panel members, and please feel free to take the floor. The first question is about the reimbursement of teledermatology consultations. I know that in the country where I live, in Belgium, those teledermatology consultations are not reimbursed. And it would be interesting to know if national health systems across Europe reimburse them compared to in-person visits, and what reimbursement barriers prevent the adoption of teledermatology in wider terms. So this is my first question. The second question, you mentioned AI a lot. So it's a huge issue and unknown issue, of course. And I would like to know how the AI-driven teledermatology so what are the tools which are necessary to prevent the AI-driven bias in teledermatology? So those are my two questions. Whoever feels comfortable, please go ahead. Maybe Professor Navarini could take the... yeah, go ahead, please.
I would like to add to that a question about what Professor Navarini said about the Skin Vision app.
Yes.
Which in the Netherlands, where I live, is well, promoted really also by at least my health insurance, and it's free to use it within the base insurance. So when I hear his comments on it, I think, how is it possible that it's so much promoted by health insurance here? And so that maybe does add to this question, because these consults are reimbursed by health insurance over here. So maybe Professor Navarini does have an answer to it. I don't know.
Yes, or maybe to the question about the AI and the bias that it generates. Yes, Matthias?
I don't know if Professor Navarini is in the line in the moment. Maybe he was.
Oh yeah, probably.
He lost connection, so maybe I can comment on this.
Yes.
So regarding AI-based solutions, there needs to be a strong regulation, and he mentioned the levels of risks and also requirements officially as a medicinal product. And in the end, the question is, are these tools which just support the derm in decision making and facilitate his diagnostics, his collection of information, or are these standalone solutions which replace the derm? And if it's the previous, if we just get support from these solutions, of course, we still need to rely on that they do the right job. But ultimately, we are in the decision situation with the patient, and there is a clear regulation of the responsibility, also the legal responsibility for this. If these are standalone solutions, we have no control, and also the patient has no control of what happens. And then I see a much larger risks, and also the question is, who is ultimately responsible? Of course, Mrs. Postu may comment on this, being also a legal specialist in this, but I think there's still an open gap that we may talk about. And the other question was about the reimbursement, and this is very different country-wise, of course. And in Germany, we have a partial reimbursement by most, but not all, sick funds. The problem is that the reimbursement from the sick funds is so low that there is no incentive for the derms to do it. And then we have no progress if it's not fairly paid.
Right. And yes, Joanna.
Yes, thank you very much, Yalcin, and thank you, Professor, for mentioning this, and also to the colleagues who raised it. I would just go back first to the issue of reimbursements. So indeed, reimbursements are not a competence where the EU can impose uniform conditions. It is not provided in the treaty that they could do so. There was a slide I could have dealt with in the for Q&A on this, with the specific provision from the treaty mentioning that, in fact, when it comes to the public health policy, the EU can only adopt measures that support the actions of the member states. Now, support is much different compared to uniform conditions, as we do in other policy areas. With respect to the artificial intelligence, it's true that with the what is called AI Act, Artificial Intelligence Act, that entered into force in August 2024, and it is currently being transposed by the member states. This was a revolutionary act that addresses several AI systems of high risk. There is a categorization of the different systems, softwares that use the AI. The Commission is working and has released, in fact, a code of practice for providers, but it is only in time and seeing how member states apply this code that we will be able to draw conclusions and to look into possible leverage for further regulating on different legal basis. There needs to be willingness from the Council, from the Member States representatives on this. So I would say, yes, in general, regulatory measures, they tend to come after the phenomena is already there. And I very much liked also the presentation mentioning the ChatGPT as a health device, medical device that could be regulated. It's not the case as of today. Yeah.
Yes, still maybe on the same topic, not like on the regulatory topic. Gunter mentioned that the data must be revocable and the patient need to have the ownership of the data. What the EU regulation says about this? Is it already the case through the prism of GDPR, for example? Ioana, the question is to you.
Yes, but could you please repeat the last part, Yalcin?
Yeah, Gunter said that the data must be revocable and the patient needs to have the ownership of the data. The rules are now they require this, right?
That's precisely what the European health data space deals with. It's what we call primary use of data. And there is a possibility, this was also in agreement with the Council in the negotiations on the Act, there is the possibility for member states to provide, when they implement this Act in their own system, to provide the possibility for the citizen, for the patient to opt out. That means that in the cases that I gave earlier, they would need to bear with them still their electronic file and have it provided to the medical doctor abroad. So it is not an automatic use of data cross-border where the member states provide for opt-out, that we will see how member states choose when adapting this system. There will be an opt-out possibility, at least where member states choose to offer this possibility to the patients. I hope this is answered your question. That's the issue. And GDPR played an important role. It was indeed an important benchmark when regulating on the provisions of the HDS. Definitely GDPR was an important pillar within.
Thank you. Gunter?
Yes, if I can, I would like to react to that. In many cases, legally, there is a framework in place that you indeed can opt out, or that you indeed in some cases, in all cases, withdraw your consent. But the problem is that the implementation is in such a way that it is far from useful for a patient to actually do it, because even in some cases you do not know who has your data, first off. And secondly, systems are sometimes very complex, and as a normal user, you do not know where you can limit the access to your data. I'm talking, of course, on the Belgian situation at the moment, but I fear it could be also the case in many other countries. Just want to mention this.
It's very good comment. Thank you, Gunter, for mentioning this. Indeed, Belgium already had in place a system. With the EHDS, there should be some harmonization, and there is an explicit provision regarding patients' right to have access to info on who viewed their medical data. So they can choose not to have their data seen by their dentist, by medical data that is outside the scope of the dentist's competence. But initially, they've seen a psychiatrist. Maybe you don't want the dentist to know about that. So there is explicit opt-out. I'm not aware currently in Belgium how confusing if the system is working or not. I would just dare also to mention that once the system is in taking place. European Commission is the monitor and the guardian of the EU treaties, and they monitor the application of union legislation. So I'm sure there are going to be reports on how this is being implemented, and the Commission is going to see whether they need to correct, to clarify certain provisions in the regulation. First, we have to see it up and running across member states.
Gunter, your hand is still up.
Yes, because I would like to react to that also, but it's indeed it's true what she said, of course, but another concern besides the fact that it is complicated for normal citizen to do. On the other hand, we have the commercial private initiatives, and those are a lot more closed off. Of course, there is the privacy regulation, the GDPR regulation, but from a simple test, we know that some providers of commercial initiatives do not even answer their clients or their patients. So I think there's a whole lot of work also to be invested in implementation and in controlling all those different actors who are active in the e-health universe. So
thank you. Yeah, well, it's all about the existing regulations and the realities that they face in the application of these rules. And Jaime has a question.
Yeah, hello everybody. Not really a question, just a comment. I do agree with the necessity of the owner of the data, which is the patient, to actually opt out or avoid somebody. We have to find ways that the patient can actually say, well, I want you to see this data, I don't want you to see that data. But at the end, we cannot, because the majority of the patients, I would say, I want my data to be at the disposal of my healthcare provider, or not. I think it's if we complicate too much what is related with the RGPD, whatever, then we're gonna take a fee. The Chinese and the Russian will do that very easily. I'm talking about all the development with artificial intelligence and all that. And Europe will keep on regulating and regulating and regulating everything. And we are on this process, of digital transformation, and you can be behind, and not having the proper care that we should have these days with all this facility of the digital transformation. So don't be too much security on it. Just, have it there, but don't complicate the way that we give access. Because at the end, I can give my code to anybody. I can show all the data to anyone I want if I just give my phone and my code and show it. That will happen a lot for sure, because people are not aware of the ways of opting in or opting out. You just put the code and show it to the doctor or whoever they want to show it. So don't be too much on the security side, and let's have access to all the best tools that we have to take care of our lives. That's my opinion anyway.
Thank you, Jaime. We have a question in the chat box by Cecilia Pulido, and I guess this question is for Alexandra Navarini, but Matthias, if you feel comfortable, you can take it. So do you validate the apps that qualify with MDR above 1 before they get to the market? Do you have a minimum sensibility and specificity threshold for them? Thanks. Sorry if I didn't get it in the proper way.
Yeah, thank you. I think Alexandra Navarini would be the better person to comment on this, but it's for sure that those MDR above 1, they go through a process of control and verification. And if it comes to us as the users, we look exactly at the power in terms of sensitivity, specificity before we use them. But I think this is more about the administrative processes And there each medicinal product has its own categorization and definition of what is certified by the notified body which does this.
Thank you. And one more question by Karima Siddiqui. I hear and agree that digital should complement the role of the healthcare provider. Given that there is a shortage of dermatologists, do you see a current or evolving role of the nurse practitioners in supporting teledermatology with access to care? Yes, Matthias?
Yeah, maybe everybody has a view on this, but it's for sure that part of the task that we do as dermatologists could also be done by assistant personnel. And if we would do so systematically, we would already save a lot of time. And the shortage in number of dermatologists is even aggravated because we do a lot of administrative work. Maybe I do 30% administrative work, 40%, which could be reduced by sound digital solutions. Regarding the nurse practitioners, I think this is maybe different in different countries, but they are even more in a shortage than the derms in Germany. So if we think about replacing derms or supporting derms by non-medical professions, they are as scarce as the derms, and this is just a move of lacking people rather than a good solution. Nevertheless, if such assistants are there, they can help a lot in teledermatology, though I would insist that the final view and the final assessment on each consultation is done by the specialist, by the derm.
Thank you very much. If you have questions, please put your hand up because I cannot see the whole screen. Or write it in the chat box. My another question would be, you partially treated this question. It's about the teledermatology platforms, and they're used by people with disabilities and people with limited digital competencies, digital skills. So do you know how they are made accessible to, because Gunter said the aim should be reducing inequalities but not creating new ones. So if you can address this question. Yes. Matthias, yes.
Again, others may also have a view and an opinion on this, but it's very important to understand who is not capable enough for cognitive reasons, for reasons of lacking technology. And we need to think about those in order to not lose them in the access process. My experience is in a country like in mid-Europe, Germany, that there are very few patients, very few, who cannot benefit from digital means and from teledermatology. Those who have cognitive inhibition, who have, let's say, dementia, they have supporting people around. So even very aged people who may not be familiar with the technology, they come with their family or with other neighbors, whoever. And this support, of course, then facilitates also the digital care. And I can give you one number. Last year, we treated more than 1,500 patients with our digital onboarding and electronic appointments. And there were 2 patients out of 1,500 who were not able. And they then took the analog way, and we wrote a letter with them.
Thank you. There is also one question in the Q&R box. I couldn't really understand the question. Maybe Tembizile Madiala could ask the question themselves.
Hello, good day to everyone. The question is that I just wanted to know if this system is being introduced to all countries, because I'm coming from South Africa, and for me, I'm a patient and I'm running a non-profit organization, and it's my first time hearing about the teledermatology or this system that I see that all countries other countries are working fine with it. And I was thinking, and I was asking, my other question is that I think the other guy covered the question that I had about the disability sector in order to access easier the system. And then I was wondering if here in KwaZulu-Natal, here in South Africa, we've got provinces and likely KwaZulu-Natal, there is more deep rural areas, which is not easier to access even any networks. And then if we will go for this digital system, is it helping more in some poor patients, or how can we assist maybe in our country to access to use this system easier, or even for us as persons with albinism, because we visit clinics and dermatologists every 6 months if there is no questionable thing that we have that is pushing us to go see a doctor. But every month we go into the public hospital or private hospital, or seeing a dermatology in her or his surgery. That is my other question. That is it working? Is it easier to access this system in public hospitals or in private hospitals or in each dermatology as a doctor? Why I'm asking specific with dermatologists, it's only that as persons with albinism, we usually go every time to see the dermatology. Thank you.
Matthias?
I was not the first to raise my hand. Maybe the woman with cutis laxa wants also to reply to this. Otherwise, I'm happy to do.
Marie-Claude, do you have an answer to this question?
Yeah, it was not specifically a question, but a reaction to what has just said about access for people who have difficulties, or access in some rural areas where there is difficult access to the internet and so on. And as I said at the beginning of this call, I've been working on tele-expertise in dermatology, which is another way of using new tools. And tele-expertise is a bit differently organized, because the patient goes to see his GP, and the GP has a link with a network of dermatologists, and the GP is taking the photo, is trained to make good photos with a dermatoscope, and he sends all the data with a secured app. This is organized by health authorities in France, and it covers many of the difficulties we've been talking about protecting data, access to everyone, and it's more friendly for the patient to talk with his GP about his derm issues, and the GP has a link with an expert dermatologist, which is a bit different way of using medicine, e-health, and I think both should be accessible everywhere. Either you are very friendly with using e-tools and you do it yourself. It leads to another question. If you receive a difficult to hear diagnosis, who is accompanying you after the act, after Dr. Matthias already answered in the chat, and we all agree that a human being is the one who should be accompanying the patient after the diagnosis. It leads to a secondary question. If the diagnosis by the app or AI says, oh, this is urgent to be treated, how does the patient have access to an urgent consultation or surgery or whatsoever? And when it's done via tele-expertise, the GP has the link already locally to the dermatologist, and so the patient can have a quick care follow-up and treatment. So that was my input to the discussion.
Thank you, Marie-Claude. Matthias?
Yes, just coming to the last comment, very well taken. And if it comes to the question how to make best use of teledermatology, as I mentioned this already, it's not a standalone solution. We need to see the healthcare environment. We need to anticipate what it means to use the technology, who to refer to, how to deal with bad or negative messages, and all this. And so I think this whole set of healthcare environment is important. It may be different in different health systems. And this leads to the question that I also wanted to address. What do we do in very rural areas, like was the question from South Africa? And my experience is, because we do a lot of such health care also in Africa, that in most countries, obviously, even in poor countries, people have access via mobile phones. And just as a demonstration, when I was talking in the last round, I just got this request here. This is from rural Madagascar. It's a request, and it's a very high resolution photo. So it was done in a rural area. It was sent by WhatsApp, which is not ideal. But my experience is that on the basis of store and forward teledermatology, a lot can be done and solved. And the rest is text interaction, which we do after this. And so I think access can be very good, except among those people who don't have any digital devices. And they may refer to local health stations. That's what you also mentioned in the comment before. GPs who are, or even non-medical health professionals may be allocated far in the periphery and take the job of promoting, of transforming the signals. And finally, I just evaluated a program on people with albinism in Kenya, because you were talking about people with albinism in South Africa. And in Kenya, they have registered probably most of the people involved. It's more than 8,000. And they get regular interaction and care online with such simple devices. But of course, they all need personal care, because there's frequent surgery, frequent also delivery of sun protection measures. And all this, of course, cannot be done in a telemedical way. So it's, again, the hybrid. They are the best combination of both, which paves the way.
Thank you very much. Maybe my last question to the patient representatives, and of course, if other panelists want to also take the floor, they are more than welcome. Carla and Gunter, patient representatives always talk about the holistic approach to the patient care. And is there any fear among the patient community that the generalizing of telemedicine can deprive them from a holistic approach, like having a psychosocial support, follow-up, and so on, just reducing it into a very technological framework.
Perhaps I should start answering the question. I think there is a danger to that. There's an issue to that. When we were developing our own app, we intentionally focused really on that part, on giving education, giving supports. But indeed, if it's only a tool for creating a diagnosis and writing a prescription, it could lose the human touch, and that would be a real shame. And if you lose the human connection, then you lose a very important part of being taken care of medicine, actually, in my opinion.
Yeah, and I would like to add that, Professor Augustin also said, I think the alternating between the personal visits and maybe the teledermatology care is good. I know, for instance, from Urticaria Care Center, where they have people on biologicals who need to come back sometimes every 6 weeks, and when they further on in the treatment, there can be longer time between the appointments. They say you don't have to meet every time in person, and we could also use maybe a phone call or an online consult, or maybe the nurse could call. And but they also insist on every now and then we need to see a patient in person, indeed, to control the total well-being. Like you say, Yalcin, the holistic view of things. Do they need maybe psychological care or whatever? Are there other comorbidities, and do we need to put on a larger team of specialists in the care for the people, etc.?
Thank you very much. Any final questions or remarks? If not, we came to the end of our webinar. I wish I could sum up some take-home messages, but the discussions were so rich that it's going to be a challenging task for me. But the good news is that we will provide the community with the post-event report, and the video recording of this event will be made available very soon. We will keep on working with our partners on the issues that are important and central for our patient community, including the access to treatment and other related issues. And speaking about the partners, first of all, I would like to thank the European Dermatology Forum for accepting to co-host this webinar with us. We deeply appreciate our partnership and our friendship with EDF, and I look forward to the new projects. Of course, I express my gratitude to our distinguished panel members for accepting to share their knowledge with all of us. I know that they have very, very busy schedule, and they really made this event enriching and interesting. Thank you also to all the participants joining from different parts of the world for your attendance and for your active participation. It is really heartwarming to see all of you always present around the critical topics.